Hi guys, today we'll talk about pain management medications, and we're going to go through a variety of different things from NSAIDs to opioids and then some miscellaneous categories. So I've got the lecture kind of broken up into different spots, so if you find it too long, feel free to stop and take a break and come back. But we'll get started here with the World Health Organization pain scale. This is a kind of a nice way to picture how to do pain medications. Basically, you want to start off with non-opioid medications. And ideally, you don't want to get to opioid medications unless you really need it. So look at adjuvants and NSAIDs and Acetaminophen. Now, sometimes pain is severe enough where you can't really get around opioids. So it's kind of a double-edged sword where we don't necessarily want to use opioids, but a lot of times we have to because there isn't really another option. We'll start with NSAIDs. NSAIDs are probably one of the most widely used medications in the world. They are over-the-counter, specifically Ibuprofen and Naproxen. They're fairly effective for a really wide variety of pain syndromes, and they've been around quite some time too. So they're cheap, effective, easily obtainable, means that they get a lot of use. Not to mention that they are not always appropriately used, but it is something that we'll discuss here today. There are 20 different NSAIDs in the market. There's some different pharmacologic categories, which don't really make too big of a difference. In fact, the mechanism of action is essentially the same. They just are slightly different as far as their structure goes. The kinetics, dosing, and frequency is really what makes an NSAID different from another NSAID. Some are long-acting, some are short-acting. And then we have different amounts of enzyme inhibition that make up their mechanism of action for different specific subtypes, which we'll talk about in a moment here. The NSAIDs work on a mechanism by decreasing different inflammatory mediators within the body. And it all starts with arachidonic acid. So arachidonic acid is the body's precursor to eicosanoids. And eicosanoids are basically just inflammatory and immune messengers. And there's a bunch of different ones. Eventually, they get converted into prostaglandins, prostacyclins, and so on and so forth. But before that can happen, arachidonic acid needs to be released by different tissues. And so what happens is that during tissue injury, your body will naturally release arachidonic acid as a way to help heal itself and provide relief for the body. And you can see the different arachidonic acid compounds that are converted from arachidonic acid at the bottom there. Cyclooxygenase, or COX 1 and 2, you can see them in this flow chart here, are a major source of production of these eicosanoids and these inflammatory mediators. And by decreasing their production, we can decrease inflammation and therefore decrease pain, swelling, therefore treat people's conditions. And they really work for a lot of different pain syndromes again. So you can use them for anything from a headache to, sprained ankle. So for whatever reason, NSAIDs tend to work quite well, and they work throughout the entire body. So basically the mechanism here is that arachidonic acid is our precursor, remember. It gets converted to different precursors via cyclooxygenase, which is the COX enzymes. And we have both COX 1 and 2. I'll talk about those more in a second, but you can see that there's different final products here. You have thromboxanes, which affect platelets and platelet aggregation. You have prostacyclins, which tend to be maybe more housekeeping enzymes that are mediators that can help actually be beneficial in places like the GI tract, and then prostaglandins as well. And we'll talk about some of the problems with inhibiting this whole process in a second. So when it comes to NSAIDs, you're looking at inhibiting either COX 1 or COX 2 or both. Most NSAIDs are non-selective for the most part, meaning they inhibit both. And the difference is that COX 1 is basically a constantly active enzyme you have in the body, and it's kind of, think of it as collateral damage when it comes to giving NSAIDs. So COX 1 isn't necessarily a target that really is all that helpful as far as pain management goes. It's constantly active, and it generally is responsible for keeping prostaglandins that are beneficial to the body at a steady state so that they're always available. So gastric epithelial cells are particularly of benefit and get cytoprotection from these prostaglandins. So if you inhibit COX-1 enzyme, you lose some of these housekeeping prostaglandins, and specifically that can be problematic in the GI tract, where you could possibly put yourself at risk for a GI bleed. We'll talk about that in a minute too. COX-2 is an inducible enzyme, and it's upregulated depending on different stimuli. So if you have some sort of an injury or something like that, it's going to upregulate itself. So COX-2 is really the major target of what we're trying to block as far as helping with pain and inflammation. So the bottom line to remember about the mechanism of NSAIDs is that while there's different selectivity, generally speaking, all NSAIDs have to have some COX-2 efficacy. Otherwise, they aren't going to really work for pain. This is a non-comprehensive chart that shows a little bit about NSAIDs and how they are selective. So they kind of group them into non-selective, some specific COX-2. So while non-COX-2 selective means that they have COX-1 and COX-2 essentially equally expressed activity. NSAIDs with some COX-2 activity, meaning that they're slightly a little bit more on the COX-2 side of things than the COX-1 side of things. We have some here. And then our COX-2, these selective NSAIDs. Now, you can ignore the bottom four here because they aren't on the market, or they're investigational and probably never will be on the market. The only one that is available is Celecoxib or Celebrex. And Celebrex is really the only pure COX-2 selective NSAID. Meloxicam and Etodolac, while they have quite a bit of COX-2 selectivity, they still aren't 100%. Celebrex is really the only one that is. NSAID safety concerns. Renal toxicity is a big one. I think we talked about this a little bit when we talked about blood pressure and ACE inhibitors, but with prostaglandins and prostacyclins can help with vasodilation in the glomerulus. And if you take that natural process away, you can end up with vasoconstriction. Now, in the short term, it's fine to get a little bit of vasoconstriction within the glomerulus. Over time, that can be problematic, and especially if you combine that with dehydration or an ACE inhibitor, you can really cause damage. So basically, the thing to remember is that PRN NSAID use, not a problem for renal issues. However, if you're dehydrated and if you're on an ACE inhibitor and you take a bunch of NSAIDs, you're probably looking at a pretty bad picture for your kidneys. And it's important that patients recognize that. And especially if a patient already has some acute kidney injury, you'd want to avoid NSAIDs altogether until that injury is resolved. Pregnancy concerns. I'm not going to go into a ton of detail on this. If you really want to know, you can look up all the information yourself. Basically, we don't use NSAIDs at all in pregnancy. There's a variety of data out there that says that maybe NSAIDs are relatively safe in the first and second trimesters. There's some studies that show mildly increased risks of birth defects, spontaneous abortion, but they're pretty rare. Even if you compare them to the general population, they're a little bit higher, but they're still relatively rare, probably pretty low risk. The problem with NSAIDs is they can have a tocolytic effect once you get closer to delivery, which we can use to our advantage in the case of indomethacin. But for the most part, during the third trimester especially, we want to avoid NSAIDs in most pregnancies. And for the most part, because their risk is maybe a little bit higher, generally speaking, pregnant patients shouldn't take NSAIDs unless they really have a good reason for it, which is rare. And then GI bleeding is the other one that is kind of the hallmark side effect of NSAIDs. And that's, again, because you're losing those housekeeping vasodilators and prostaglandin and prostacyclin that help protect the gastric mucosa. And if you lose those, you put yourself at risk for possible GI bleeds. Again, it's sort of like renal toxicity, where if you're taking them, NSAIDs PRN, very seldomly, you have virtually no risk. If you take them regularly, that's when your risk increases and at high doses. And maybe if you combine that with things like not consuming enough fluid when you're taking the NSAID, or taking it on an empty stomach all the time, you can end up with maybe increasing your risk here. You can see some of these NSAIDs listed here. Ibuprofen having probably the lowest risk on the market, which is good because ibuprofen's over the counter and extremely common. You've got Naproxen kind of in the middle here. Generally speaking, Naproxen, ibuprofen are thought to be okay with GI bleeding risk. One that's not on here is ketorolac. It's probably one of the higher risk ones. So there's a variety of risk stratification within the NSAID class. This is just a diagram to show the possible mechanism here. So basically what you have is a mucosal gel layer in the GI tract, and if your body can't maintain that because it's getting disrupted with NSAIDs, you end up exposing the epithelial cells to the acidic conditions of the GI tract, and therefore you can cause tissue damage, bleeding, ulceration. Risk factors for GI bleed. Again, regular NSAID use is a big one, but older people, poor renal function, prior ulcer, risk of GI bleed. If they're on some sort of anticoagulation, that would be an increased risk, of course, too. If you want to prevent this, you can limit the use, so keep it to PRN and not chronic. Use something that's COX-2 selective specifically. Proton pump inhibitors like Prilosec, omeprazole, those work well, and if you're going to be on a chronic NSAID regimen, are essentially required for patients. It's recommended that they be on some sort of chronic acid suppression therapy if they're going to be on regular NSAID therapy. Other drug interactions, we talked a little bit about the problem with ACE inhibitors and NSAIDs. One other thing I'll say is that with our housekeeping prostaglandins and prostacyclins, you get some natural vasodilation with that. If you're constantly taking NSAIDs, you're working against that system. So you're basically going to be working against your body's natural vasodilation, meaning your body can be more likely to clamp down, cause increased blood pressure. So for people who are hypertensive, it is important to ask them about their NSAID use, because if they're taking ibuprofen regularly, they may not realize that that's actually having a negative effect on their blood pressure. Doubling up on NSAIDs is generally frowned upon. There's no real point. Some patients may not realize they're in the same class, so they may get over-the-counter Aleve or Naproxen and Advil or Ibuprofen and combine them, not thinking that they're essentially the same thing. So that can cause problems as well. I'm not going to spend a ton of time on the COX-2 selective cardiovascular risk. Basically, there's a drug on the market called Vioxx a while ago that was removed because there seemed to be a twofold increase to CV events compared to placebo. So there's been a lot of research into NSAIDs and cardiovascular risk. Basically, the underlying mechanism is that there's some thought that there's increased thromboembolic complications, and this is probably related to prostacyclin production decreases due to the NSAID use, which predisposes the vascular epithelial cells to endothelial cells, to injury. So there's a couple other speculated mechanisms. We aren't 100% sure, but that's the major theory behind this. Celebrex is still on the market, or Celecoxib, which is a COX-2 selective NSAID. Its risk hasn't been shown as high as Vioxx, and specifically, its dosing has been restricted. So we tend to keep Celebrex at pretty low doses to avoid this CV risk. The moral of the story with NSAIDs and cardiovascular risk, if you have a patient with a significant cardiovascular history, like they've had a heart attack or an MI in the past, or for whatever other reason, you probably want to avoid NSAIDs altogether. In most patients who don't have underlying CV risk, it's relatively minimal, and especially if they're taking it as needed, it's virtually impossible to have any risk associated with this. The one thing I will just say to remember, all NSAIDs do inhibit COX-2, so they all have some CV risk. Naproxen is thought to have the lowest risk out of all of them, so that's maybe a reason to use it more so than some of the other ones. We'll talk about Naproxen too and some of its other advantages as well. And there's some risk here that I put down. The risk is small, 1 to 2 per 1,000 person years, and again, pretty much non-existent risk with short-term therapy. And really, what they're seeing the risk at is chronic, long-term NSAID use. Aspirin and NSAID can interfere with each other. Basically, what happens is the NSAID competes with binding on the specific site of COX-1 with aspirin, and you end up with irreversible inhibition that affects the platelet, and that can have there's just kind of a pharmacodynamic interaction there that basically diminishes aspirin's ability to work. And that's another reason why they think that NSAIDs and cardiovascular risk might be a theory, because patients who are on aspirin at the same time might have this interference. Salicylates, I put here, they're kind of an NSAID. Aspirin is the salicylate probably everyone's heard of. It has a role as an antiplatelet agent, but really no one is using this for analgesic use. The reason is you have to take pretty high doses of aspirin to get any pain relief, and it's got pretty bad dyspepsia that it causes at high doses, so generally we aren't using it for pain. Salicylate's a medication that I think is forgotten about. It's kind of like, I think about it as a hybrid between like ibuprofen and aspirin. It's not as risky as a full NSAID with respect to like renal dysfunction and GI bleeding, but also doesn't seem to be quite as effective. It's something that could be an option for some patients. All right, acetaminophen I put here because there's really not another good place to put it. Acetaminophen is not an NSAID technically. It doesn't really fit into any category. It's kind of its own thing. There's a couple different words for acetaminophen. APAP is a really common abbreviation. Paracetamol is the European or British term for it. The dosing is there in case you're curious. Available orally, rectal, and IV. We even have IV acetaminophen. IV acetaminophen is kind of controversial. It's really expensive. And there haven't been any good studies that say that giving somebody IV acetaminophen versus PO acetaminophen is beneficial. There have been a lot of interesting studies looking at acute care settings, specifically with post-surgery patients and obstetrics patients that who get IV acetaminophen use less opioids over time. But those same studies haven't looked at if that's any different than people who are getting PO acetaminophen. I think anecdotally some providers really like this, but again, it's like $150 a dose compared to, generic Tylenol, which is probably a couple of cents per dose. So there's definitely a big cost difference there. So if you're thinking about prescribing acetaminophen in the IV in the acute phase, just know that you're probably going to have to jump through a few hoops because we don't like to give it to patients unless there's really a good reason to. If patients like NPO and they really need it or something. Max is 4 grams per day. This is a maximum dose you should definitely know. 4 grams a day is pretty much the standard. There's some push from the FDA a while ago to decrease that recommendation a little bit, but that never really got anywhere, so it's still 4 grams per day. Acetaminophen itself is an okay pain reliever, probably not the best one out there, and there's a lot of studies that say it's maybe just slightly better than placebo. It is a pretty good antipyretic, meaning it works well for fever reduction. So that's where we see it used quite a bit, especially for kids. You can use it in conjunction with any other pain medication, so you can combine it with NSAIDs, which I don't think people really understand. I've heard providers recommend that people don't do that. And the rationale I've heard is because people might get confused and end up, like if they're alternating Tylenol and acetaminophen, or acetaminophen and like ibuprofen, if you're alternating those, you may forget which one you took and then end up taking double of one, and then you end up accidentally taking too much Tylenol, which can be problematic. But I think as long as your patient's competent and can keep on a schedule, if they want to try both of them, that's definitely okay. There's actually no reason why you can't take them both at the same time. You can take a dose of Tylenol and ibuprofen at the same time. They have different mechanisms, and they're essentially different medications altogether. So you can take them at the same time. Safe in pregnancy. There's a variety of information that seems to kind of come and go about, is acetaminophen having problems? Because a lot of women probably take it during pregnancy. I think the most recent thing I read was something about a risk or link to ADD, which was a poor study that wasn't really well-founded in anything, and I don't think it really went anywhere. But, they're always scientists are always looking for reasons for things. So if you're trying to find something with respect to pregnancy implications, acetaminophen is a good drug to look at exposure of because so many people take it during pregnancy. Acetaminophen is combined with a ton of over-the-counter things, cough and cold medications, opioid painkillers like Norco and Percocet are combined with acetaminophen. It's really important that if you're prescribing or recommending anything, or your patient's taking anything that's a combination product, that they understand that there's Tylenol in there. A lot of patients don't know that there's Tylenol in, and there's really no point to it. It's kind of marketing on whoever's making these, especially these over-the-counter products, like these cough and cold products. I mean, is there really any reason to put a little bit of Tylenol in there? Is that enough Tylenol even to provide analgesic relief? It's debatable, but pretty much every product on the market that's combination, usually they throw Tylenol in it, and it's important that patients are aware of that. Doesn't really have any drug interactions. It does get metabolized via the liver, which we'll talk about in a second. And it doesn't really affect any metabolic processes in the liver unless you take a lot of it. Acetaminophen is hepatotoxic in overdose, and that's probably one of the biggest risks it has and why people get a little bit concerned with Tylenol. So we've said 4 grams a day is about the maximum. You can see toxicity anywhere from 7 up to 12 grams in a single day or in an overdose situation. Acetaminophen is probably the most commonly overdosed medication because it's so easy to get and it's in so many things. The problem with so the way this works is that I don't have my diagram in this lecture, but I'll just briefly explain it. Acetaminophen is metabolized in the liver, and the liver has sort of a rate-limiting series of enzymes, and it can only metabolize so much Tylenol in its proper pathway in a certain amount of time before it just depletes itself of its enzymes. So that's where the 4-gram recommendation comes from, which is a bit conservative. The liver can probably handle a little bit more than that, but we don't want to obviously push the liver to its limit every single day. And what happens is if you push that limit and you run out of that initial enzyme, Tylenol metabolism takes a different pathway in the liver, and the liver uses alternate enzymes to metabolize it. What ends up happening is you get accumulation of a fairly toxic byproduct that is hepatocellular, that causes hepatocellular toxicity. And eventually you can end up with liver failure in really severe cases. Fortunately for Tylenol overdoses, we have a pretty good treatment for that called N-acetylcysteine that basically helps the liver regenerate that enzyme it needs to metabolize the Tylenol. So most patients who overdose on Tylenol don't get to that point. If they were to overdose on Tylenol and not get treatment for a while, that could be a point where they maybe have enough liver damage at that point where it's difficult to do anything about it. But usually if the patient's caught quickly, it's fine. I say this will be covered in detail during our tox module. That's for my PA students. We don't do a tox module in this class. If you're interested in Tylenol overdoses, you can definitely look into it on your own. But that's basically, those are the basics that I think you need to know. One other thing, I didn't put a mechanism of action on either of these 2 slides because we don't really know how Tylenol works, interestingly enough. One of the oldest drugs, probably one of the most commonly taken drugs in the world, on a daily basis. We don't know how it works. It's probably thought, there's some theory that there's maybe a COX-3 enzyme it inhibits. It works in the central nervous system, so maybe there's something centrally with pain that it helps with, but we don't fully understand how this drug works. All right, ibuprofen. Most commonly used NSAID, Advil, or Motrin are the brand names. You'll see a lot of combination use with ibuprofen, and this is another drug that's in combined with a lot of different things, cough and cold medicines and whatnot. I've got the dosing there for you. Max 3.2 grams per day. That's a pretty high dose. You rarely see people go up to that. Where I would see that dose used maybe is for osteoarthritis patients that have relatively healthy kidney function. That's a really high dose, though. Normally what you might see is like 800 milligrams 3 times a day. As a high-end dose, and so that approaching that 3.2 gram is pretty rare for most patients. The OTC tablets are 200 milligrams. So if you have a patient and you want them on a higher dose, just make sure they understand what the dosing is. They should take more tablets than what you like if you want them on 600, obviously tell them to take 3 tablets and know that the OTCs are only 200. You can give prescription ibuprofen for higher strength, but there's unless you really are concerned about patient adherence, there's not a whole lot of point to that. I mean, they're going to be paying money for a prescription that they could just get over the counter and take multiples of. Ibuprofen has pretty low GI bleeding risk, got relatively good side effect profile overall as far as NSAID goes. It's a relatively decent NSAID. It's not like on the low end of potency. It seems to work pretty well for a lot of people. Clinical trials have consistently shown that ibuprofen has better control than acetaminophen and is also a pretty good antipyretic. So as far as pain relief goes, this drug is going to be more effective than Tylenol in the majority of cases. However, we don't use NSAIDs in pregnancy, so that's one case where Tylenol would trump this drug. Naproxen or Aleve or Naprosyn is another really commonly used medication. The one big difference between this and ibuprofen is it's longer lasting. So Aleve has like a 12, 14-hour half-life, so you can take it twice a day as opposed to ibuprofen where you're taking it, 4 times a day. So it's a little bit more convenient. May not be quite as potent. I think clinical comparisons have shown that ibuprofen might be a little bit better of an analgesic overall, maybe a little bit more potent of an NSAID. But naproxen's convenient, and it's pretty commonly used, and people seem to get a good response to it. Some other ones here I just want to point out. I'll talk about diclofenac in a second on the next slide. Indomethacyn's one you guys will probably be familiar with. That's mostly not used for its NSAID property, but used as a tocolytic during labor and delivery. So that's a drug I'm sure you guys have covered in other lectures. But it is an NSAID. Ketorolac is one probably to be somewhat familiar with too. This is a really potent NSAID, especially IV, and it's the only NSAID we have that's IM or IV. Oral ketorolac is available. However, it's essentially as effective as ibuprofen. So don't think prescribing somebody oral ketorolac is going to give them all that much benefit over a standard OTC NSAID. But the IV and IM products are quite potent, and their potency almost matches that of kind of a low-grade opioid as far as how good they are at reducing pain. So in the short-term acute phase of pain, especially maybe post-labor and delivery, ketorolac is probably a good drug to give somebody. And a lot of times what I'll see is our OB patients will be on maybe a short course of ketorolac, and then they're switched to oral ibuprofen. Be very careful using ketorolac. It does have a very high risk of GI bleeding, and it does have a high risk of causing kidney problems too. Again, it's very potent, so it's going to be more potent not only in its analgesic effects, but also in its side effect profile. So it's restricted to 5 days use max. Usually what you do with ketorolac is use it for a day or two, and then switch somebody to ibuprofen. Not all patients will even need it. Some patients can just go straight to oral ibuprofen and be just fine. But it is a nice option to have because it's potent. It's not an opioid. And you can avoid the GI tract if your patient's NPO. Topical diclofenac is a medication that it does come orally too, but more commonly gets used topically. Voltaren is a gel product, and Flector is a patch. And the nice thing about this is that it works systemically to absorb, but it also works really well in local areas too. So you get some systemic effects, but it's minimal. Mostly this would be for like somebody with maybe joint pain or pain in a very specific localized area of the body. And you can see this graph comparing like diclofenac oral, and you get 100% systemic absorption versus the gel at different doses and how minimal systemic absorption you get. So the point is that you get lower amounts of side effects with lower systemic absorption. So you don't get as big of GI bleeding risk. You don't get as big of kidney injury risk, and that's a nice advantage to these products. So if you're looking for a product that's going to be a little bit less invasive as far as systemic exposure, these could be a good option for some people. Some other non-selective NSAIDs here. However, meloxicam is an interesting drug because it's once daily dosed, so it's pretty convenient from that standpoint. And it's mostly COX-2 selective, so it doesn't have as much COX-1 activity. And then there's some other medications I'm not super concerned about. And then there's Celebrex. Celebrex, again, the only viable COX-2 on the market, pure COX-2 on the market. Some other ones are heavily COX-2 selective. This is purely COX-2 selective. Minimal GI risk, but we usually still prophylax with acid suppression therapy using a proton pump inhibitor. Dosed twice daily, doesn't have any effect on platelet function, which is a nice advantage for patients who have cardiovascular history. But in those patients, you probably wouldn't use this drug anyway, so I guess it's maybe a moot point. Don't use anything more than 200 milligrams per day, and because that can increase your cardiovascular risk. All right, let's talk about muscle relaxants quick. So if you need to take a break, this is a good break spot. Muscle relaxants, I'm not going to spend a ton of time on them. Basically, they work centrally. They do a lot of different things as far as their mechanism of action goes. They generally have sedating and anticholinergic properties. They're kind of on their own island as far as you can combine them with NSAIDs, acetaminophen, opioids. They can all be together. So it's a different way to treat pain potentially. Usually what you're looking at is short-term acute relief. So I think of the standard patient who these medications would apply to is somebody who, like, quote unquote threw out their back or is having back pain or back spasms, or some other muscle pain or muscle spasm, something short term. We can use muscle relaxants for long-term relief too, for patients who have maybe like neurologic injuries. I'm not going to go into that in this lecture though. Cyclobenzaprine is Flexeril. Flexeril's mechanism is not understood very well, but it has some effect on alpha and gamma motor neurons centrally, and some central effect on norepinephrine as well. How that creates analgesia is debatable. We don't really know how it works. In fact, a lot of the physicians I work with don't necessarily think Flexeril does all that much. I think it's kind of like a placebo. It's a way to give somebody something that's non-opioid, but may satisfy their desire to have some sort of pain control. But as far as clinically, it doesn't have, it's kind of an old drug, not a lot of evidence for it, but it's been around a while and it's used fairly frequently. So that's that. A couple other medications, methylcarbamol, carisoprodol. There are other muscle relaxants too you might see, metaxalone. They all kind of fall into the same category of muscle relaxant. They're all fairly sedating, anticholinergic. Soma itself is actually a controlled substance, so that one actually has some potential for abuse per the DEA. All right, that's it for muscle relaxants. Again, not much I want to talk about there. Opioid analgesics are a much bigger category. Opioids are used all over the place for acute pain. They really are the most effective thing we have for pain. Patients will respond very differently to opioids. So some patients may not get much of an effect at all. Some patients may feel nauseous on them. Some people may be just sleepy on them. It just really depends on the patient. There's a lot of different agents out there with different pharmacokinetics, with different dosage forms. The side effect profile of opioid is fairly hallmark and straightforward. So we'll talk about that. Opioids are fatal in overdose because they decrease the respiratory rate, and that's what kills people from too much opioids. So it's very important people don't take too much of an opioid if they're being prescribed it. Generally safe to give in pregnancy for the most part. Basic opioid stuff I want to talk about. Analgesic effect. You end up getting minimal to significant pain relief, again, depending on the patient. There is no ceiling dose to opioids. You can really push an opioid as high as the patient can tolerate it. At most points, you reach a maximum effect because the side effects catch up to the analgesic effect. So you can push an opioid dose to get more and more pain relief, but you may not be able to get to the point where you would like to be because the patient is sleepy or their respiratory rate's dropping. Of course, we don't want that to happen. Tolerance to opioids develops over time, so the longer somebody's on one, the more they need to get that same analgesic effect. And the mechanism of opioids, I'll talk about this on the next slide and what receptors they're hitting. But it's important to know that this isn't really doing anything to the actual source of pain in the body. All it's doing is it's masking how your body is perceiving the pain. So it alters pain perception and the body's response to pain within the central nervous system. So it's basically tricking your body into thinking you don't really have pain. Sedation. Some opioids, small doses, not highly sedating. Large doses can be significant. And again, the ceiling of sedation effect would ultimately be decreased respiratory rate and death. There are synergistic effects with nonsteroidal anti-inflammatories and benzodiazepines. They work very well to achieve pain control as a combination. So a lot of times you'll see like NSAIDs and opioids prescribed. You see Tylenol and opioids prescribed a lot with respect to Norco and Percocet, and that's a synergistic effect there too. Opioid receptors, we have mu receptors are the most popular thing that most people know about. Opioids are agonists on mu receptors, and so mu receptors are receptors in the body that interact with your natural endorphins that are produced through various processes. And opioids are designed to interact with those as well in an artificial sense. So it's designed to make your body feel less pain, euphoria, but along with that comes respiratory depression, GI effects, maybe some bradycardia, constipation's a big one too, especially with post-op pain. Definitely want to be careful with that. Adverse effects, I've got them all here. So again, respiratory rate, sedation, constipation, those are probably the biggest ones. Some patients will get nauseous on them, not all patients. Histamine release, some of them are more likely to cause itching than others, and we'll talk about those ones in a second. And dependence. So some patients will become physically dependent to them. Some patients may develop a psychological addiction to them as well. Opium is the founding father of the opioids, I guess you could say. It's derived from poppies. Those are poppy plants in the picture there. And you saw that I had I'll go back to this picture quick. This is traditionally how opium is harvested. So this is a poppy that hasn't, the bloom hasn't opened up yet. And so farmers, if you want to call them that, will go through the fields and make cuts on the the poppy plant itself, and this latex-like substance releases out. It dries, they scrape it off, and that is actually how opium is produced. Opium is a variety of products. So if you just take pure opium, there's a lot of stuff in it because it's from a plant. You'd expect that. It's got 12% morphine in it. So that's where we get morphine from, and that's why opium has an analgesic effect and why it's been used as an analgesic for quite a long time. You can also, of course, take opium and extract heroin from it, or cook it down into heroin, and that's where heroin is produced as well. So poppy fields, well, I say farmers, quote unquote, are mostly involved today in the illicit drug trade. We don't use opium really for much medicinal purpose anymore, and we're generally just using synthetic products that mimic these, or like morphine, but a synthetically produced version, as opposed to extracting it from opium. Opium is used as a tincture sometimes for really severe chronic diarrhea. Remember, opioids do cause constipation. They work in the GI tract and slow things down. That can be excuse me, sorry for that yawn. Opium can be used for chronic diarrhea, and that's really the only time you're ever going to see it. So quite an unusual product and pretty rare to see used. I'm never going to ask you anything about a structure on an exam, and I don't talk about structures very often, but just to show that opioids are all kind of the same structure. So here's morphine, codeine, hydrocodone, which is Norco, oxycodone, which is what's in Percocet or OxyContin. These ones I kind of forget. This one's fentanyl. You can see that. So the point I'm showing you is that there's kind of a different gradient as far as opioid structures. So morphine is considered to be the most natural one, if you want to put it that way. It really is. It's just a lab-produced version of the naturally occurring substrate within opium that is causing the analgesic effect. So it's taking the most active form of opium and putting it into just a pure drug form. And then you have codeine. Codeine gets metabolized into morphine at a very like a 1-to-10 ratio. So codeine is essentially, think of it as a much less potent version of morphine. Hydrocodone and oxycodone are both a little bit more potent than morphine. And these are more what we call semi-synthetics, meaning that they have basically the same base structure, but they have all these they have some modifications to their structure, making them a little bit more of what we call a semi-synthetic. So then you get to the pure synthetic. So this is fentanyl. I think this one might be Meperidine, and this one I think is hydromorphone or Dilaudid. So you can see the further we get down into maybe more potent opioids, fentanyl, hydromorphone being quite potent compared to some of these opioids up here, you get more synthetic looking structures. And that also is advantageous because it tends to eliminate some of the side effects. So if somebody gets a high amount of histamine release from morphine and a lot of itching, if you give them fentanyl, they probably won't get any itching from that because it doesn't have the same reaction with the histamine receptors. So there's some advantages to doing that as well, in addition to increasing potency. All right, morphine's a really old medication. It's still quite popular. One of the earliest isolated plant alkaloids that was used in modern medicine. It's both cheap and highly effective, making it quite nice to use. It's available orally and IV. There's a couple different products. There's immediate release tablets and liquids. There's extended release products. MS Contin is the extended release product that's pretty commonly used. Avinza, and Cadian are other products too. For chronic pain management, these would be a choice to think about. Available IV, it has a bit of a slower onset than some other opioids, so as far as acute use, it may not be the highest efficacy, but it is still quite effective. And if your patient has healthy kidneys, it's a nice option. If they don't, morphine is metabolized into some other active metabolites that can end up accumulating in renal dysfunction. So if you have a patient with compromised renal dysfunction, morphine can kind of catch up with them and cause some compounded effects. All right, hydrocodone and oxycodone. I kind of talked about these with the structures a little bit. They're similar. They're both more potent than morphine. Oxycodone is slightly more potent than hydrocodone, but they're again quite similar as far as dose conversions go. Hydrocodone is combined always with Tylenol. There's no pure hydrocodone product on the market, at least not right now. Hydrocodone is combined with acetaminophen. Historically, this was called Vicodin. Vicodin is probably the word that a lot of people still use in the general population. Vicodin itself doesn't really exist anymore. Vicodin was 5 milligrams of hydrocodone and 500 milligrams of acetaminophen. A couple of years ago, the FDA decided that no opioid product should have more than 325 milligrams of acetaminophen in it. And that product, which is 5 milligrams hydrocodone, 325 acetaminophen, is Norco. So Norco has been around a while, and it's generic. They're all generic, so it really honestly doesn't matter what brand names you call them. When somebody tells me they take Vicodin, I just assume they take Norco because you physically can't get the Vicodin 500 anymore. These products used to come in a whole array of acetaminophen strengths and different hydrocodone strength. So you might have 5 milligrams hydrocodone, 10 milligrams hydrocodone, 7.5 hydrocodone. Acetaminophen might be 325, 500. There's even like a 750, I think, or 700 milligram Vicodin product at one point called Vicodin ES. Those don't exist anymore. All you have are some variable hydrocodone strengths, but every single product now has just 325 milligrams of Tylenol. So the Tylenol component doesn't change. You can get different strengths of hydrocodone, though. Same thing goes for the oxycodone products that are combined with Tylenol, like the Percocet products. Percocet has always been 5 milligrams oxycodone, 325 acetaminophen. That hasn't changed at all because that meets FDA criteria. You can't get the higher strength Percocet with Tylenol, though. You can't get like the 500 Percocet anymore. You can get like a 10 milligram oxycodone, 325 acetaminophen. So hopefully this makes sense. You can vary the amount of narcotic in these products, and while 5 milligrams for both products is the most commonly used one, either being Norco or Percocet, you can get 10s or 7.5s too. As long as that acetaminophen product is staying constant at 325 milligrams. They're both controlled 2. This is a new change with Norco. Norco used to be control 3 for a really long time, there's some debate about this. Some people think it was really nice because it's control 3, meaning that like if your patient ran out of medication and maybe they just had a C-section and they're in a lot of pain, they ran out of their Norco, didn't get a refill, it's Saturday, there's clinics not open, you're on call, you get a call in, and the patient's like, I'm really in pain, can I just have like a few to get me through until I can come in and get checked out on Monday? You can't call in a prescription for Norco anymore. You used to be able to call in a C3 to a pharmacy. You cannot call in C2s, it's illegal. You have to have physical hard copies. So the patient would have to have some way of getting a hard copy from you, or eventually what's going to happen is that they'll probably end up in the emergency department if their pain is that severe and they can't make it, till Monday. So there's some benefits and risks to that. The benefit to scheduling it is because hydrocodone had no business being a class 3 ever. It's essentially the same as oxycodone. So the fact that we were scheduling them different really made absolutely no sense. And it is an incredibly highly abused product. So there's really no reason why it shouldn't have the government's highest level for a medically used product for controlled substance. It just makes sense. So again, there's pros and cons to that. But this is the case of this is the situation we find ourselves in currently with the class 3 product. What else? Usually a bit less itching and slightly more effective orally than morphine. These products do not come IV, so while morphine does, these products are oral only. They're fairly inexpensive too, with the exception of OxyContin. OxyContin is the probably one everyone's heard of. It's the long-acting form of oxycodone. And there's a whole bunch of debate on that whole product too. It's used for chronic pain management, which is actually probably a pretty good product to have for that. However, OxyContin ranges anywhere from 10 milligram product all the way up to like an 80 milligram product. And the fact that 80 milligram product exists makes people nervous because people were stealing it or obtaining it illegally and grinding it up and injecting it or snorting it. And that's a lot of oxycodone to be getting at one time. OxyContin actually had to reformulate their product in order to make it less easy to crush and to inject. But that's a whole other topic in and of itself. Hydromorphone is Dilaudid, probably the most effective medication, most commonly used medication for acute pain management. It's about 8 times more potent than morphine, has a much more rapid onset, and doesn't have any metabolites. No renal issues to think about, and very minimal itching. It's much more commonly used inpatient than outpatient. Really, you generally rarely see people get prescribed like oral Dilaudid. It just doesn't happen that much. Usually they're giving something a little bit less potent like a Norco or a Percocet. The oral Dilaudid is fine if you dose it correctly, but Dilaudid is much more commonly used IV. Again, because it's really fast onset. It doesn't last that long. It's got kind of a short half-life, and it's a very potent analgesic medication. Patient-controlled analgesia, I just want to touch base on this really quick. If you work in a hospital setting, you've probably seen these before. What it is, it's a syringe, and it's usually filled with hydromorphone or Dilaudid, sometimes morphine. And it provides a continuous infusion of an IV product, and then the patient, via this button they can push, can give them boluses of medication every so often. And you can set these pumps to, the patient can't get in and alter these, but they basically have a lockout interval every so often, so they can only push the button so many times, and they can max their dose out. So you can't overdose yourself just by pushing the button, assuming it's set appropriately. Fentanyl is a pure synthetic opioid. It's extremely potent. So when we're talking about these other drugs, like for hydromorphone, we might give a milligram IV. Fentanyl, we're looking at like giving 50 or 100 micrograms. So it's a very, very potent medication. And not to say it's any better than anything else. Again, with opioids, it's all about potency, and it's all about how you dose them. If you give somebody 50 micrograms of fentanyl, you're probably getting the same effect as if you give them half a milligram of Dilaudid. It's really not much different. The nice thing about fentanyl, it's a pure synthetic, so there's no cross-reactivity. So if somebody is still getting a histamine response on hydromorphone or Dilaudid, they likely won't have that experience at all on fentanyl. Fentanyl isn't available orally. It's available IV. It comes as a transdermal patch as well for chronic pain. It does come as this lollipop too called Actique. I think somebody photoshopped this kid with the lollipop, but I think it's a funny picture. But this is the actual product. It does look like this. It's kind of got this lollipop on the end, and you're supposed to basically cheek the lollipop for a certain amount of time and pull it out, and that gives you a certain amount of medication. I rarely ever see these used. More commonly used maybe for chronic pain or acute on chronic pain, maybe like a cancer patient would be more common with that. But fentanyl IV is popular in the acute phase all over the place. It's especially very popular as epidural. So it's our most commonly used epidural product is fentanyl. Our epidurals are a combination of fentanyl and ropivacaine at our hospital. Ropivacaine provides the local nerve block, so it blocks the nerve impulses to the lower part of the body, allowing analgesia. And then the fentanyl will infuse slowly into the epidural space and then get distributed systemically to help with some pain management that way. So there's a couple different mechanisms there that the epidurals use. But fentanyl is the common epidural that's used in most hospital settings. All right, patches. I just have some information on patches here. Highly doubt you guys are ever going to be doing anything with patches. If you're ever considering prescribing a fentanyl patch for somebody, that's a good sign they should be referred to a pain specialist. But here's some information just in case you're curious. Opioid onset, you can see there's some different products here. Don't worry about Fentanyl and remifentanil are kind of like these super short-acting, fast-onset fentanyls. But regular fentanyl, you can see here having a fast onset. Compare it to hydromorphone, or what's this one? Morphine, you can see here kind of as a slow onset compared to everything else. So nothing you didn't know already, right? Meperidine is Demerol. I put it on here just because it's sort of a historical opioid, has no role in pain management. So never prescribe this or think about giving this to anyone for pain. There's absolutely no reason to do it. If somebody is telling you to prescribe Meperidine for pain, you should ask them why they're thinking that, because it's inappropriate. Every once in a while, I have somebody ask me for Demerol, and I'm just like, what? We don't use Demerol for pain anymore. The reason why is it has a toxic metabolite that causes seizures, among other CNS side effects, and it does accumulate fairly quickly. It also has some other problems here that I've listed down here. What we do use it for, patients who are experiencing rigors, so they're shivering, maybe in the perioperative phase, you might see this. So we use very low doses of Demerol to counteract this. And low doses meaning that they probably wouldn't even have much of an analgesic effect. But really, that's the only reason we'd use Meperidine. Don't use it for any other situation. Methadone is an interesting drug. Methadone has the longest half-life for a non-extended release opioid, about 24 hours. Its analgesic duration is relatively short at first, but if you increase dosing, people will tend to get a longer exposure to it. Historically, methadone hasn't been used a lot for acute pain management, but I think that's changing. Methadone's relatively cheap. It's fairly effective. If we go back to our onsets, you can see methadone actually has a pretty fast onset compared to some of the other medications. It's actually fairly similar. It's not all that far behind. It's actually right on the track of hydromorphone if you look at it that way. So it's got a pretty fast onset. But I think people think of methadone most commonly as a medication associated with treating opioid dependence. So patients who have opioid addiction history, methadone is one of the cornerstones of treatment. Methadone, while it is an opioid, it doesn't have as substantial of a euphoric effect as other medications do. It also has some other properties to it that can help mitigate some withdrawal effects. So it's got serotonin norepinephrine reuptake inhibition, which we're going to talk about during the psych lecture this week as well. But that combination plus having some NMDA antagonistic properties, which allows for maybe a bit of a dissociative effect, and also some mild sedation as well. But that combination of it being an opioid plus serotonin norepinephrine reuptake plus NMDA antagonism, combination of it seems to work very effectively to allow people to feel like they're getting some sort of a medication that's similar to what they used to be addicted to without getting the high, and it mitigates the side effects of withdrawal. Methadone clinics operate a couple different ways. People don't go to the pharmacy to buy methadone unless they're taking it for pain. If people are taking it for opioid dependence, they go to specific clinics that are set up for this, and they get a dose once a day. Some patients who have been compliant for a long time may get take-homes. I've seen patients get like 2 weeks of take-home doses at a time. Methadone does have street values, so it is something that you'd have to make sure your patient was okay using and not going to go sell it to somebody or possibly be in a situation where it gets stolen. But ultimately, you may work with patients who are on methadone treatment programs. And the idea is that ultimately there's two pathways. Methadone patients could wean off their methadone over time. Some patients may be on methadone for almost their entire life. They may just take a daily dose for life because they can't manage not having the opioid because of their addiction. So it just depends on the patient, really. Conversion and comparison. This site up here that I've linked is a really good website. It allows you to type in all types of different conversions. It's very user-friendly. If you're considering any type of pain management in the future, it's a good option. So if, let's say, your patient's been inpatient post-C-section, having a lot of pain, maybe they've been using quite a bit of Dilaudid IV, you're trying to transition them to oral, and they've been using a lot of oxycodone, but they're still using a little bit of IV, but they're okay going home with oral, and you want to combine it. So maybe you want to figure out, okay, they used 10 milligrams of hydromorphone IV in the last 24 hours, and they used I don't know, 30 milligrams of PO oxycodone in the last 24 hours. So how much is that total? How do I give them enough medication to get them by in the acute phase and also wean them off? So those are conversion things that you may have to do in practice. This is a fentanyl patch conversion form. Not concerned you know that. Buprenorphine is a partial agonist. It's another medication that's used quite frequently for opioid dependence, so as an alternative to methadone. It's partial agonist, meaning it doesn't elicit full opioid effects, and it competes for other opioids. So if you're on buprenorphine and you inject heroin, heroin's going to be a lot less effective because buprenorphine is going to compete much more strongly for those mu receptors. It's not going to provide that same response. A medication is called Suboxone, which is pretty common. It's a film, and it also comes as a tablet, but it also has naloxone in it, which we're going to talk about in a second here. Hyperalgesia, I'm not really going to talk about. This is more for long exposure to opioids, really high doses. Probably not something you're going to see a whole lot. Naloxone is the major medication we use to help with opioid overdose. And not necessarily, and we think about maybe opioid overdose as like a heroin abuser, but you can think about somebody in a perioperative state. So if your patient just got out of surgery and had a C-section and maybe got a little too much Dilaudid or fentanyl during that procedure, maybe they need just a little bit of Narcan to help balance that out. Narcan is a pure opioid and pure mu receptor antagonist. So it competes and replaces the opioid on the site of action. You can give it IV, IM, sub-Q, neb, nasal. It's not absorbed orally, but every other way you can give it. The onset's in minutes. It's fairly quick onset. It only lasts about 30 to 120 minutes. So a lot of our opioids have a longer half-life than naloxone. So you may have to redose. One thing I would be careful with using this is precipitating withdrawal. So if somebody's been on a fair amount of opioids, you want to be a bit gentle about it. Unless it's life-threatening, like their respiratory rate's crashing, they're going to stop breathing if you don't give them to it, then it's okay to give a higher dose. But you may end up with a patient who's all of a sudden was in a euphoric state, now is very dysphoric and is very angry. So you may end up with somebody who possibly could lash out at staff or something. So just be careful with this medication. If you gave this to somebody who doesn't have any opioids in their system, they aren't going to notice anything. It has no other effects, no side effects or anything. It's just an antagonist. There's kits available for people to take home. So if you have patients you work with who have a history of opioid addiction, a kit's a good thing to give. It's an naloxone kit where they can withdraw it. The family can have it. Maybe if they have family members who they stay with, friends who they stay with, even if they're injecting heroin with other addicts, if they have a kit available and one of them happens to overdose and one happens to be conscious enough to notice, they can inject this and hopefully save somebody's life at the scene as opposed to having them go to emergency department. Naltrexone, I'm not going to spend a lot of time on. It's essentially think about it as a longer acting version of naloxone, not for emergencies. It comes as an IM shot or PO, opioid dependence only. Maybe used for alcohol dependence too, but I'm not going to talk about that. But yeah, so that's all I really want to say about naltrexone. A drug you might see in your practice, especially in the inpatient side, is nalbuphine or Nubane. Nubane is a mu receptor partial agonist and also is a kappa agonist. So it has some opiate effects, but also works on some different receptors as well. We don't really use this for pain management. You could, but really what we use this more for in the acute phase is opioid-induced itching. So in the perioperative phase, this is if they're getting some itching because of the opioids they've been given, this is a medication that can prevent that. Methyl naltrexone is a specific medication for opioid-induced constipation. And again, I don't think you're ever going to see that that's more of a chronic pain specialist thing. I didn't talk about codeine at all because I don't really consider it an analgesic medication. I think of it as a medication that is one of those where you have a patient who really wants something for pain, but you don't want to give them a real opioid, so you give them codeine. Codeine is metabolized to morphine. It's about 1/10 the potency again. It's often combined as cough syrups, Robitussin, AC. It is over the counter in some states too. So it's a very weak opioid, but it is an opioid. It comes as a tablet form too. Tylenol 3 is the common name for that. And that's 300 milligrams of Tylenol and 30 milligrams of codeine. So codeine itself, again, it's a very weak opioid, but it is something you could consider potentially as a weak analgesic or more so as a cough suppressant. Dextromethorphan is a common OTC cough suppressant that has an opioid-like in structure. It doesn't affect really the same receptors. However, if you take it in really high doses, like if you drank a whole bottle of it and overdosed on it, you can end up with some kind of interesting side effects because of that. Oh, I put this other note. Cough suppressants aren't very effective. They've done a lot of studies on cough suppressants of all kinds, and the bottom line is cough and cold products don't really do anything. There's huge sections of over-the-counter cough and cold products, and essentially it's kind of funny because none of them really help with anything. You just have to wait out your cold and get over it. Antidiarrheal medications are also opioid related. Remember, our opioid products cause constipation. So if you have diarrhea, these could be products. I think I saw some forum posts mentioning things like loperamide or Imodium. Loperamide is an opioid that isn't absorbed systemically, so there's no systemic side effects. It's PO, stays in the gut, and helps keep things moving that way. Or sorry, the opposite. It would slow things down, right? Lamodal is another product. Diphenoxylate is the opioid-like structure. It's combined with a medication called atropine, which is anticholinergic. The atropine is really low doses, and it's in there to discourage abuse so that somebody's not going to like inject the diphenoxylate. It's kind of a silly idea because atropine isn't like going to prevent the diphenoxylate from working. It's just going to make somebody feel anticholinergic, so they're going to feel dry and constipated, and it doesn't really make sense to me. It's a controlled substance. It's a class 5, and you can try it kind of like the same way you try loperamide. Maybe a little bit more potent than loperamide. It is prescription only. Chronic pain, I'm not going to touch on this much because I think in your practice you're probably going to refer people who are chronic pain, but you may have chronic pain patients with you. Basically the point of chronic pain is to look at somebody should be on a long-acting product. So somebody's taking a ton of PRN like Percocet. That's not chronic pain management. They should be on something that's giving them long-acting, then they have something immediate release like a Percocet or regular oxycodone for breakthrough pain. Withdrawal is usually not something we're too concerned about for patients using minimal amounts of opioids. Usually 3 weeks of daily use is where you get at the point where you're concerned. It does depend on the drug, how potent it is, the dose, how much they're taking, and length of use. Symptoms for your typical agent, 3 to 4 hours after the last dose, you're going to get craving, anxiety, fear, 8 to 14 hours, restlessness, insomnia, GI side effects, some other things too. 1 to 3 days, tremor, muscle spasms, vomiting, diarrhea, tachycardia, chills. Withdrawal of opioids is fairly uncomfortable and problematic for the patient, but it's rarely fatal. In fact, it's likely not to be fatal whatsoever unless your patient has some underlying problem. So maybe if they have underlying heart disease or if they're malnourished or something to begin with or sick to begin with, could possibly be fatal for them, but it's rare to be fatal in a normal person. Any opioid can be given for treatment. Excuse me, another yawn. Methadone, probably the more common one. We already talked about some other medications that can be used, benzodiazepines, clonidine. Side effect management. Talked about itching with Nubain a little bit, but you can give antihistamines for itching with opioids, so diphenhydramine and hydroxyzine. Hydroxyzine is probably the most common one. Hydroxyzine's brand name is Vistaril. Hydroxyzine is a little bit less sedating and less anticholinergic than its friend Benadryl or diphenhydramine, and that's why it's probably more commonly used. Constipation, really be careful with opioids and constipation. If you have somebody who's in a fair amount of pain for whatever reason, you're prescribing them, make sure that they have some sort of bowel regimen on board. And I think it's more important to be on top of it than to play catch up. So don't wait till your patient's extremely constipated and then try and do something. If they're going to be on regular opioids, if they're taking their PRN Percocet 4 times a day, you might be like, just take some Senna with Docusate on top of it, or take Miralax or something like that. Bulk forming, increasing your fiber and water content in your diet is great and will help, but ultimately opioids are strong enough where they're probably not going to help all that much, so you really want to make sure you have some sort of medication to assist with that. Addiction's a huge problem with opioids. I don't think I need to tell anyone that, but it is. The risk for getting addicted to opioids is about 3 to 5%. So anyone who takes an opioid, it's about 3 to 5% they might develop some sort of addiction. Not to say that they're going to be hooked for life, but they may feel like they want more. Patients should be made aware of their risks. I went to an addiction specialist talk once, and he said, would you prescribe somebody an anticoagulant and not tell them that the risk is they could bleed? Because the risk is similar. It's maybe a low risk of having some sort of a minor bleed, 3 to 5%, something you should be aware of. And this is something you should be aware of when you prescribe opioids, just so you know that some people do become addicted to these medications, especially if you have a history of substance abuse. A lot of challenges with prescribing and dispensing these drugs have huge street value. There's a lot of people who doctor shop, unfortunately, and who try and get these medications either because they're addicted or because they're selling them. In fact, there is a huge wave of addiction to oxycodone and oxycontin, and then now that the government's kind of cracked down on prescribing of that, and people are getting busted for dispensing like these pill mills in places like California and Florida that were prescribing massive quantities of oxycontin basically for addicted people, those places have been shut down. But to replace them, the quality of heroin coming into our country has gone up substantially, and heroin's actually relatively cheap. It's cheaper to get heroin than it is to buy oxycodone on the street. So most people who have been addicted may have turned to heroin. So we're seeing a spike in heroin addiction that we didn't see a few years ago, mostly because of this. So a huge amount of social issues around the addiction of opioids, and may have seen on the news the FDA just came out with some new restrictions for how to use opioids and stuff. It's going to take a lot of culture change to really make a big difference. It's going to take time to make a big difference. But the moral of the story, I think, as a provider, you should be very conscious of prescribing opioids and be very careful. Don't prescribe anything you don't need to. Don't just offer somebody an opioid because you feel like it's the right thing to do. If you feel like they're going to be in a lot of pain and they might want it, you could discuss pain management options, but I wouldn't necessarily offer it to people freely. And be very careful with patients who you don't feel comfortable with, who are trying to maybe get you to prescribe medications like this. It can be a big problem, and ultimately you can be on the line as a professional if you're prescribing medications for somebody who is, shopping around. You don't necessarily know that, but there are tools you can use. One of them is the Minnesota Prescription Monitoring Program. Got the website there. As a provider, you should register for this, and you should look at this if you're ever concerned about a patient. If you have a patient who you're working with who you think is using a lot of opioids or is doctor shopping, this program will show you what medications, what controlled substances they've filled within like the last year, where they filled them, who's prescribed them. So you can see if they're getting all the same medications, same provider, if they're shopping around different providers using different pharmacies. So you can see all that stuff on that website. It's very helpful. Just some quick other things here. Tramadol is kind of an opioid. It has some weak mu activity, but inhibits reuptake of serotonin and norepinephrine, kind of like methadone does. It's oral only, has regular and extended release products, usually dosed every 8 hours. It was uncontrolled for a really long time, recently changed to controlled substance, which is probably a good thing because this medication is abused a lot. You can use it with an NSAID in combination. You wouldn't use tramadol in combination with an opioid, though. It's too close. So you could use it in combination with any other analgesic, really, though. Lidocaine patches are a nice thing for something that's local, that is maybe like you can see this patient, upper back pain or lower back pain, or maybe local leg pain. They're pretty big patches. You can see this is like a full size. You can also cut the patch to fit different smaller areas or fit around areas too. You can apply up to 3 at a time, so there can be quite a bit. The thing about lidocaine patches to remember is that it's a 12-hour on, 12-hour off. If you have the lidocaine on for too long, you can possibly get a little bit of systemic effect. Lidocaine is an antiarrhythmic drug. It can cause some cardiovascular problems too. So, but this is if you have patients with postherpetic neuralgia or some neuropathic pain, lidocaine can be very helpful for different areas, or even just like a problem spot on their back that's really sore or stiff. Lidocaine can help with that, and it's non-opioid, doesn't have any other class that it's competing with, so it works well with other things. Neuropathic pain I'm not going to talk about a lot. There's different manifestations of it that are listed there. Opioids, again, the mainstay of this is don't give an opioid if you don't have to. It applies to neuropathic pain. We haven't really talked about these drugs yet, but there's some anti-epileptic agents, gabapentin, pregabalin, carbamazepine, which we're going to talk about in the next lecture for this week. And then antidepressants, which there's some tricyclic, and serotonin, norepinephrine reuptake inhibitors like Cymbalta, which we'll talk about in another lecture this week as well. And that's all I've got for you. Any questions, let me know. Thanks.